Good evening, all the students present here. Today, topic is infectious disease and tropical medicine. And the speaker that we have here is Dr. Anand Joshi, sir. He's a consultant, intensivist, and physician at Government Hospital, Hyderabad. So you can start. Thank you.
Thank you, Fatima, and welcome back. I think this is the sixth or seventh talk, a lecture on the series of the infectious disease. I will just try to get the settings done. So far, we've covered a majority of sexually transmitted diseases. We have covered HIV/AIDS. We have covered major tuberculosis. We have covered all the spectrum of antibiotics, general introductions. Now we are going to the specific diseases. I'll try to transition and club the diseases as much as possible. Hello? Hello? Yeah. I will try to transition it in a very gradual manner. Other diseases, the smaller diseases, it's practically impossible to cover all the infectious things, but important points will be covered. I've tried to squeeze as much in one session, but I don't want to overload it also. Otherwise, it doesn't make sense. So in today's one, I'm going to cover almost 6 diseases. As a continuation of the tuberculosis, let's look into another mycobacteria, which are very clinically important from the Indian perspective, and that's the leprosy, also called as Hansen's disease. So it's a chronic infectious disease caused by Mycobacterium leprae and transmitted mainly by the respiratory droplets. So it's a respiratory droplet transmission. There is a lot of evidence for its presence in soil and also the vector. So there is a little bit of debate among the epidemiologists that. Sorry, somebody's asking a question.
All the aspirants, it's going to be a very interactive session. You can also unmute your mic or you can also type it in the chat box. Thank you.
Yeah, if somebody types in the chat box, do you mind just letting me know so that what it's typed so that I can respond to that? Right. So coming back to the Mycobacterium leprae, so there is a lot of debate among the epidemiologists that it can get through the soil and vector, but that's again a debatable. It has a predominant inclination for this mycobacteria to affect the skin and the peripheral nerves, mucosa, testes, upper respiratory tract, and eyes. It has been found to be very much endemic in tropical countries, particularly Indian subcontinent that extends right from Pakistan till Myanmar, and Brazil, Indonesia, and Southeast regions. As other Mycobacterium tuberculosis, it's a very slow growing intracellular acid fast bacillus. Incubation period is really long. It can take from 2 years to 40 years with an average of 5 to 7 years. So when you got this infection, you will never trace it back. Its doubling time is almost 14 days in the mice, so it cannot be cultured. So it's not an easily grown thing. There is one important thing which has been mentioned, that the transmission requires a prolonged close contact. So if you have just passed through somebody who has sneezed out a Mycobacterium leprae, it is very unlikely that you might be getting it. Another important thing about the pathogenesis or pathophysiology is that host immune response will determine the disease spectrum, and I will tell you what a disease spectrum is. So those who's got a strong immune cell-mediated immunity, they will have a tuberculoid kind of leprosy, and those who has got weak median immunity will have a lepromatous leprosy. And the person depending upon the in between them will have a varied thing from tuberculous to lepromatous, which is classically called as TT as a tuberculoid, BT as a borderline tuberculoid. BB is absolute borderline. Then we have borderline leprosy, and then the lepromatous leprosy. And each of them will have its distinct feature, and and the infectivity will vary for these people. Classically, these three things are differentiated based on the lesions or the symptoms, like the skin lesions, nerve lesion, where in a tuberculoid type we have only few sharply defined annular macules and plaques are seen with the central clearing. Again, as these skin lesions, which are much more demarcated, they become more and more lighter and less demarcated when it comes to the lepromatous side. When you do a biopsy, what you will see is there will be a more of a giant cells in the skin lesion for a tuberculoid, whereas you'll be able to see the acid-fast bacilli when in a lepromatous side. In terms of involvement of the nerve, skin lesions anesthetize early in tuberculosis. Near lesions sometimes enlarge, and the nerve abscess is most common in borderline tuberculosis. Remember, abscess is a protective mechanism for our body to contain the bacteria. However, this in lepromatous leprosy, where there is less of cell-mediated immunity involving, and it is more of the bacilli which is causing a problem, you have nerve palsies. They are much more eaten away, and there will be hypoesthesia, which will be a late sign. In when you're trying to make a smear and do an acid fast, these acid fast bacilli are more likely to be seen in a lepromatous as compared to the tuberculoids. There will be a lot of lymphocytes in the tuberculoids, whereas there will be less in lepromatous. The surrounding cells of the macrophage differentiation will be classically seen as a tuberculoid one, whereas in lepromatous it will be less differentiated. So is for the Langerhans cells and the lepromin test. See, the lepromin test is, as you know, it is the immune reaction to the injected bacilli. So when you inject it in the tuberculoid type, where you have a strong cell-mediated immunity, obviously your lepromin skin test is going to be positive. However, when it's a weak cell-mediated immunity, as in lepromatous leprosy, you won't get it. The CD4, CD8 count again will be less more in the tuberculoid and less in the lepromatous leprosy. Then we need to understand something about the leprosy reaction. So there are type 1 and type 2 reaction with another what is called as Lucio phenomena. And all these things why we need to know is because it has a therapeutic implications. Why we need to understand. See, there are so many spectrums for each and every disease. You need not understand each and every disease, each and every bacilli's behavior. But whatever you try to know is or try to understand is should have a direct therapeutic implications or mortality importance or survival thing. That's the reason you learn all these things. So out of various manifestations for Mycobacterium leprae, we have this tuberculoid lepromatous leprosy, and there is something called as leprosy reaction. So the type 1 reaction, which has got again two component downgrading and reverse reaction, this reaction is like T cell mediated. Hence, because it's a T cell mediated, it causes nerve damage, and it is limited to tuberculoid type and borderline types. Clinically, there are signs of inflammation in existing lesions with low-grade fever, signs of neuritis, particularly ulnar and perineal nerve are common. So if the nerve gets damaged completely, then you may have a wrist drop and a foot drop. If you're not treated with the steroids early, it may cause irreversible nerve damage within 24 hours. So it is so important. Now, if this reaction occurs before the starting of antibiotic, it is called as downgrading of the reaction, and histologically it becomes more and more of like a lepromatous. But if the reaction occurs after starting the antibiotic, it's called as reversal reaction, and histologically it becomes or is seen as a more of a tuberculosis. The type 2 leprosy reaction is also called as erythema nodosum leprosum. So it is more of an immune complex mediated systemic symptom, because here the T cell mediated immunity is not a great. So the body will always try to react in another branch, which is the immune complex mediated. And hence, once the immune complex mediated, it has more of a systemic effect. You get a systemic symptoms. So exclusively for lepromatous end of the spectrum, there are painful erythematous nodules, there is malaise, high-grade fever, there is a neuritis, lymphadenopathy, glomerulonephritis, orchitis, uveitis, all the itis you can think of, what you get as a immune complex mediated. People may develop anemia, leukocytosis, abnormal liver function, and it can be lethal and cause death. So always remember these things. So this phenomena you will see in your lifetime, even as a physician. There will be some phenomena which will be more of a systemic effect, and there will be some phenomena which will have much of a localized effect. In your life or in your practice, you would come across those with a systemic effect will have, which are much more sicker. You are much more worried, and you tend to hospitalize them. And these systemic effect is mainly because of this immune complex or just generalized thing. Whereas most of the cell mediated things, you will get more of a localized complaint. And this is what is happening in the leprosy reaction. Lucio phenomena is seen in the Caribbean and the Mexican region. It's an immune complex mediated reaction caused by infiltration of AFB in endothelium. So all these blood vessels, arteries and veins, they have got this endothelium, and this AFB guy goes and infiltrate and causes a local thrombosis, causing an ischemic necrosis of the skin. It causes thrombosis of dermal vessels and might end up becoming a fatal, because if this thrombosis is widespread, then it becomes a fatal thing. Diagnosis is by the classical skin lesions, where there is no sensation or the anesthesia. There is a nerve thickening. If you do an histology of the skin smear, you may find an acid-fat bacilli. So classically, you get it with the skin or nerve biopsy, and that's how you definitely diagnose it. There used to be a lepromin test. However, they are not for the diagnosis, because it is like Mantoux test, and it may have positive or negative aspect of it. Hence, if the person has got leprosy and you're doing a lepromin test, it was more for the classification. So if it's a positive, it's a tuberculoid, and if it's negative, it's likely to be lepromatous. The differentials for the skin lesions, anesthetic patches, and other systemic symptoms with multi-organ involvement are many, like sarcoids to leishmania to lupus, histocytoma, lymphoma, syphilis, yaws, granulomyelitis, and some disorders like vitiligo that can cause hypopigmentation. In lepromatous leprosy, sputum can sometimes, rarely, can be also AFP positive, and then the people may get treated for pulmonary tuberculosis. Now, remember, the pulmonary tuberculosis regime and the leprosy regime are different. WHO has given a clear-cut guideline for multi-drug therapy regimes for a possibacillary, and they are very clear. They have divided into two: possibacillary and a multibacillary. Possibacillary is a tubercular type, and multibacillary is a lymphotype. Multibacilli means there are too many bacilli, and possibacillary there is less bacilli. So the common one are the rifampicin and dapsone. But for the multibacilli, you have to add a clofazimine, and the duration is on the longer side. The drug and the dosage, uh, drug dosage and the time is already mentioned. There are few other regimes, which are, some of them are intensive regimes and which can be used. That is beyond the WHO recommendation. What about the leprosy reaction? So the drug of choice, obviously, because this is an immune reaction, you have to silence your immune system. That is the prednisolone. It needs to taper over 3 to 6 months. For a type 1 reaction, which is more of a tuberculosis type, thalidomide is not useful. Type 2 reaction is still the drug of choice is steroids. However, sometimes the spontaneous resolution occurs in less than 1 week. If you are using thalidomide, which is you will be using it for this failure of the steroids of the 2 course, then you have to make sure that you're not giving to a pregnant or a childbearing women. Alternative are the high dose clofazimine. Lucio phenomena, there is no treatment. You just have to be careful, closely monitor. It will resolve by itself, or closely monitor it for the secondary bacterial infection, and you have to treat it. Complications of leprosy are known: neuropathy, destroying the nerve, causing deformity, clawfoot, foot drops. If it's involvement of the ocular or testicular, you may get a blindness or infertility. So we'll go to the next one. Any questions on this? Any questions, guys?
You can take that class.
Sir, what
Yeah.
is the main area of question coming in leprosy in MRCP? It's regarding the treatment.
Yeah, so yes, correct. One is will be the diagnosis. How would you go for the diagnosis of the treatment? It will be the skin biopsy and demonstration of the acid part bacilli. There are, because most of the people will tend to say, oh, the culture, then they will say PCR and then ELISA and this and that. No, this is still old school thing going on. One is a diagnosis. Second thing will be the what is the lepra reaction, type 1, type 2. And how do you treat it, because this is against the, it's not an antibiotic which we are treating, right? Then will come the thalidomide thing. So thalidomide is a very important thing when it comes to an MRCP description. So there are, these are the points where people make a mistake. And of course the treatment. So treatment would be, as you say, rifampin and dapsone and clofazimine. So this is how it will be mainly a clear-cut thing, specific point to point. That is what I have touched. Otherwise, there is too many things to be discussed in a leprosy. I remember a lot of questions coming up on the leprosy reaction, because there are so many reactions and so many things people tend to forget. I have tried to pick up those points which will be more theoretical and the practical aspect of it. Yes, there are other things also there which I have not mentioned. I may would have missed, but this is from my best of my knowledge, which is more of an exam-oriented, focused talk. Anything else? Can we go to the next one?
Yes.
Yes, sir. Thank you.
Correct. So now that we know about the Mycobacterium tuberculosis, now you know the Mycobacterium leprosy, which are both acid fast bacilli. Now you come to a non-tuberculous mycobacteria, which for the Westerners is a very, very, very important topic. For us, as much as the tuberculosis and leprosy are the important, same for the Westerner, non-tuberculous mycobacteria is an important topic. They don't belong to any MTB or complex or Mycobacterium lepra. The thing is, they're widely found in environment, that is soil, water, and dust. And they are found more as an opportunistic pathogen and do not usually infest the healthy individuals. So why they are important? Because in the Western countries, UK, US thing, lot of people with a transplant you will come across. They will be immunosuppressed, and for these people opportunistic pathogen becomes a very high priority. So clinically relevant, what you will see is a Mycobacterium avium complex, also called as MAC, Mycobacterium kansasi, and Mycobacterium abscessus. So these are the clinically relevant non-tuberculous mycobacterium. As I said, their infections are increasing, especially in developed countries, because plus people are not much aware. So now the clinicians are, the examiners are actually stressing these things in the exams. More common in older immunocompromised group or those with a lung disease. Cystic fibrosis, which is not common in India but common in the Caucasians, they will have these things. Then you have a lung fibrosis, and you have lung transplants. So all those things are very important. The thing about this NTB is it is not there is no documented person to person transmission. So that becomes an important, because MTB and Mycobacterium leprae, because they go through the droplets and person to person transmission, they are called as third world country problems. But then they have suddenly elevated this non-tuberculous mycobacteria. Oh, we are not third world country. We are still having this. So they have quickly elevated it as a fancy. So there is no documented person-to-person transmission. That is one of the reason. Whereas the risk factors, COPD, bronchiectasis, HIV/AIDS, cystic fibrosis, and immunosuppressive therapy are the one. Now, classification of the non-tuberous mycobacteria spectrum. There are many. I'm just mentioning a couple of them, but there are like Rouen classification based on the pigment and the growth speed from 1 to 4. However, for our clinical aspect of it, what we need to know is there are slow growers and there are rapid growers. So slow growers are Mycobacterium avium complex, which is very common, and kansasi and Mariam, and rapid growers are abscessus, fortuitum, and chilone. Non-tuberculous mycobacteria enters the body via inhalation, ingestion, or direct inoculation. Now, it can be from the soil or from inanimate objects. Unlike TB, they do not establish any latent infection. So that is again an important aspect of it. If you treat them, then they can be cured. Clinical disease occurs mainly in those with the structural lung damage or immunodeficiency. We have spoken about it. It forms a biofilm and resists phagocytosis and persists in macrophages. Now, this becomes a very challenging when you are treating. Don't be in an impression that because it's a non-tuberculous mycobacteria, you may not get a pulmonary involvement. Yes, definitely you get a pulmonary involvement, and it completely resembles the tuberculosis. So your history taking, your epidemiology, where the patient's background, where it is coming from, all of this thing will matter. They come similar with chronic cough, fatigue, weight loss, hemoptysis, and you can get a cavitatory lesions and bronchiectatic changes as you get in tuberculosis. So it is a very, very similar thing. You may get purely lymph node involvement, especially in children, where you get a painless neck swelling, also called as cold abscess, which you get in otherwise tuberculosis. Skin and soft tissue infections are also seen. Rarely, MAC has shown to cause any disseminated disease, but they've been found more in an advanced AIDS, which is a CD4 count is less than 50. So remember, the clinical manifestations are not much different from the tuberculosis. So you have to be very, very careful when you are trying to diagnose it. As I said, it requires a very high index of suspicion with a clinical, radiological, and microbiological film. Sputum for AFB, you will definitely get an acid fast or fluorochrome smear. Now, the thing about the non-tuberculous bacilli is that they are not only acid fast positive, they may appear as a gram positive. So they may have a gram stain positivity with the beaded rods. Now, this may give as a false positive, gram positive. So you may end up saying that, oh, this is a gram positive organism. No, this is a false positive gram positive. Actually, this is an acid fast bacilli. So ball lavage or lung biopsy can be done for the smear if the sputum is negative. Now, as for the other tuberculosis, we are also having a PCR and 16S RNA sequencing for species specification. However, the primary diagnosis remains with the sputum smear or bronchoalveolar lavage or lung biopsy smear. So how would you differentiate between non-tuberculous microbiome versus tuberculous microbiome? This question would be asked very commonly. So you can say tuberculosis is contagious with a person-to-person transmission. Non-tuberculous microbacteria is not. Tuberculosis can stay inside the body, can be latent, can come out when the immune suppression immunity goes down. NTM disease indicates an active infection. Tuberculosis responds very well to rifampicin, isoniazid, pyrazinamide, and ethambutol therapy. Non-tuberculous requires a different lesion regimes. NTM has a more indolent progression, often misdiagnosed as pulmonary tuberculosis. PPD test may be intermediate in NTM and latent TB. However, they will be large, more than 15 ml. Then it signifies TB. Now, these are the shortcuts which we are trying to establish with this PPD skin test. If they are less than 15, then probably non-tuberculous or latent TB is the diagnosis. For the treatment, you need to have a prolonged treatment. As you note that it forms a biofilms, it resists the intracellular destruction. So you need to provide a long treatment, more than 12 months post-culture conversion, mostly for, on an average, it stays for around 18 months. Now, as for the pulmonary tuberculosis, you need to use multiple antibiotics to prevent resistance. So the drug of choice depends upon the species and drug susceptibility. You have to look for the monitor for toxicity like LFTs, hearing test, and visions, especially for ethambutol. Surgical interventions, as in the old school, they used to remove the whole chunk of lung, which is full of tuberculous bacilli. They are still relevant when it comes to non-tuberculous mycobacteria. So if your species are known, which is very important, you get a MAC. MAC requires or macrolide, azithromycin or clarithromycin, plus rifampicin and ethambutol. If it's a severe case, you can add amikacin. For Kansai, you have rifampicin, isoniazid, and ethambutol for 12 months. For abscesses, it's a very notorious, it's a very highly resist. So combination of clarithromycin, amikacin, and one of the cefoxitin, imipine, or tigecycline is required. Alternatively, there are other drugs which can be added or which can be replaced, are the fluoroquinolones, doxycycline, and linezolid. What are the challenges in the management of non-tuberculous mycobacteria? It's difficult to distinguish colonization versus disease. There is a long duration of treatment with potential toxicity, and whenever there is a long duration of treatment, the adherence is going to be poor, treatment fatigue is going to be there, and then the resistance develop, and that's where the challenge comes in. So that was the completion of the mycobacteria and the non-tuberculous mycobacteria. Any question on that?
Yes, sir. So actually, in mode of transmission, you tell there is a mode of inhalation route also for the transmission of the disease. And in the previous slide, you told me there is no person-to-person transmission. So how it is possible for inhalation to be the mode of transmission?
I was waiting for this question. Okay, you're dusting something. You're dusting working in a soil, right?
Okay, sir.
You're working in a soil and it just splashes up, and then you inhale it.
Okay, sir. Okay, sir.
Right?
Okay,
So
sir.
it's very commonly understood that when we call as a droplet infection, we are so much focused that we only think that if this other person sneezes, then only it happens to me. But it is not like that. Inhalational infection doesn't mean that it has to be person to person. I will just go bypass this thing. And we had, this is about 20 years back, we had this case of, I think, bone marrow transplant person who who became very sick, and the patient was kept that they should not be kept with the other patient. So she was kept in another building which was completely newly built. Now, no, not completely new. It was an old building which they were renovating, honestly. And this lady develops aspergilloma in her lung. And now we know that, of course, aspergilloma can stay in your nose, you can stay in this thing, but we were trying to figure out where this, we were trying to save this lady. She was kept in isolation. People were wearing masks. They were very strict, barrier nursing, everything was happening. We started as usual blaming somebody must have sneezed, somebody must have this thing. Then later the ID medicine team later found out that this aspergillus, they scraped it from the old walls, building walls, which had a seepage happening there. Then we realized that when you talk about an inhalational thing, and that's where she inhaled, it was floating in the air, and that's where she inhaled the whole bunch of fungus. So it's quite interesting when we take the things very granted, we assume it, but when you, this is what I call it as a read between the lines, right? Make
Yes,
sense?
sir.
Yeah. I had the same question, don't worry. So that's why I was waiting if somebody asked me this question. That's good. Any other question? Okay, can we go to the next one? The next one is the treponemal disease. So we have this Treponema pallidum, Treponema leprosum. So there are a wide range of species of this thing. Two important things I'm going to talk about it in this is the leptospira and Lyme's disease. So it's an acute treponemal infection caused by Leptospira species. It is the most common zoonotic infection worldwide. So you may see it in England, you may see it in Australia, you may see it in US. At the same time, you also see it here in India. Now, these Leptospira or the spirochetes, they enter via skin or a mucosa after exposure to water or animals. So classically, you're seen during the rainy season, people walking with a barefoot in the dirty waters or enter to a dirty waters, you will see this kind of infection. So we have risk groups like farmers, sewer workers, and unhoused persons. So what would be the diagnosis and type? So the spectrum of Leptospira is very big. It can be as mild and asymptomatic, and they may rapidly go, not all of them necessarily, some of them may go to fetal organ failure. Remember, deaths have been reported with the leptospirosis. It's very dreadful, and if you miss the diagnosis, then the person definitely dies. So there are two forms. The milder form, which is called as anicteric form, it is milder and it has a biphasic illness. Now, this is a very hallmark of this leptospirosis. There are not many diseases in infection which comes as a biphasic illness. And the severe form, we are going to see this in the next slides. The severe form, also called as Weil's syndrome, is an icteric form, which is a very severe with a multi-organ failure, particularly renal and hepatic, with widespread hemorrhage. Either it is a transition from anicteric form or it may come straight away as a Weil's syndrome. And the mortality goes very high as 40%. Now, for the clinical and lab findings, the patients classically it is described as fever with jaundice. So the fever, chills, headache, abdominal pain, cough pain, myalgia, it will come as a viral or tropical, specific things which you can call it. Some of the signs are very classic: conjunctival suffusion. You do get jaundice, you get brain involvement, you get abdominal mentation. There will be high bilirubin, high LFTs are deranged. There will be renal failure, leukocytosis, all the features of sepsis. Leptospira in this kind of situation may be isolated from blood, CSF, and tissues. Diagnosis is usually nowadays by PCR, but it can also with the serology, with the MAT or ELISA. Now, the first phase would be, say, if it's a mild or anictric phase, if it's coming from anictric phase, it settles down in couple of days. And then as you think that the patient is improving, suddenly he starts deteriorating. Now, remember, this is not because of the leptospira per se or the failed therapy, but it is because of the immune phase. It's an immune reaction. And this may transition into the severe form. Now, with this can clearly be confused with the Will syndrome or the icteric phase. The complications are again going in a multi-organ failure with the myocarditis, aseptic meningitis, acute renal failure, and pulmonary hemorrhage, which is again a very, very dreadful thing. And this happens usually in the immune complex related. Usually prevention is the best treatment. Avoid contamination with water and food. If you are planning to go in these kind of situations where it's too much of rainy, you're going on a vacation somewhere, then try to take a doxycycline. There has been vaccine, but it has a limited availability. How do you treat and what are the prognosis? So again, the doxycycline is a drug of choice. Alternatively, you can use an amoxicillin. In severe cases also, you can escalate higher penicillins. Piperacillin tazobactam is there, or ceftriaxone is there. However, I would continue to use doxy and add these kind of extra medications like penicillin or ceftriaxone. Jerisch-Hexmer reaction, because if there is a massive spirochetal load and if you give penicillin and there is a massive destruction, it may cause an intense inflammatory response. And it is usually a self-limiting. You just have to be supporting to that. Non-icteric is almost never fatal, but icteric has high mortality, as we have discussed. I would personally admit all the patients with any more than one organ failure, whether it's a jaundice, severe disease, these people require an ICU admission and monitoring. Any questions? Yes, I have a little bit rushed through this.
So what is the dose of doxycycline and what is the duration of it?
Duration is from 7 to 10 days, but I usually give it for 14 days, depending upon the severity. If the severity is less, then 7 to 10 days is what I would go. But if it's a severe patient is ICU admitted, then I will continue doxycycline and add piperacillin tazobactam or ceftriaxone. Anything else? We'll go to the next.
Yes, sir.
Yeah. So it's a Lyme's disease. Now, this is a very common, you may see this in Europe and US. It's a tick-borne disease. And any idea why it's called as Lyme's disease, whereas its causative agent is Borrelia burgdorferi? Obviously, it is not related to the causative agent, and it must be somebody who would have discovered or from where you have discovered, right? So Lyme is a place near Connecticut in US, so that's why it's called as Lyme's disease. It is passed through it is a tick-borne. So the tick is Exodus, and there are a variety of species of the Exodus in various places. America, they're different. Europe is different. Australia, it's a different. And their reservoir includes mice, deer, and rodents. Usually, these tick bites, and they bite and they feed on you for more than 24-36 hours. And this disease is found when the ticks are very active, like in spring and in summer. 3 stages of Lyme's disease have been classified, which we'll see next. The classical one, besides your inflammatory presentation, fever, chills, myalgia, headache, stiffness, the classical sign, the key sign is called as where the where the tick bites, it causes a small maculopapular lesion, which gets cleared from the center. It's called, it is seen as a classical bullseye lesion. And this is called as erythema migrans. If you see that, usually seen in the groin or in the armpit or where the tick has bitten you. Other systemic inflammatory signs, headache, stiffness, arthralgia, and arthritis are known. Diagnosis is very difficult. Usually it comes from the clinical and the serology. So you have to combine both of them because this can be easily missed. Even with the serology, you can have a false positive. Inappropriate test like other like PCR or culture are not recommended. So you need to have again a high index of suspicion. As I said, it comes in the 3-stage. It's an early and localized stage where you have this bullseye, erythema migrans, and flu-like illness. Second, this Borrelia disseminates through the blood. That's bacteremic phase, and it develops into the secondary lesions. So you can see a satellite lesions away from the original lesions on the skin. They will have fever, and they may involve the neurology, cardiology, or ophthalmology. So neurologically, they may end up with a facial palsy, especially seventh nerve palsy, and or confusion, seizures, and aseptic meningitis. When it involves cardiac, it may end up with a myopericarditis, carditis, arrhythmia, heart blocks. And if it's involving the eyes, not necessarily all of them are involved, but if it's involving eyes, then you may get conjunctivitis, keratitis, and panophthalmitis. So if you get a red eye with that, you may confuse it with the leptospira. But these are the overlapping diseases. The stage 3, once this dissemination goes, it becomes a late persistence phase, and it may occur over the months and years. Chronic arthritis, chronic encephalopathy, chronic skin changes will keep on happening. As I said, diagnosis is based on the clinical and the lab finding. So even in the lab finding, once you are clinically suspecting, you need to have a 2-stage approach. So you should do first ELISA followed by a Western blot. When you're doing an antibody titer, IgG, IgM, especially IgG, 4-fold rise in antibiotic titer is a diagnostic one. You may still get a false positive if you are just purely relying on some blood test. Prolonged high single report of IgG or IgM is not evidence of active infection. Just say that we had a recent infection. But the rising titer is what you have to see at the interval of a week or so. Other lab tests are like inflammatory changes, high ESR, LFT involvement, leukocytosis, anemia. Lyme disease, there are no proven congenital syndrome. Post-Lyme symptoms are not linked to the active infection. So when you see it after, say, Lyme disease, the person had about 6 months back. After 6 months, they may still have some arthritis, may not be a active infection, but they are a post-Lyme syndrome. Differentials are the diseases caused by tick, spider bite, cellulitis, bacterial arthritis, and meningitis. There is no human vaccine. Trials are going on for that. For the prevention, avoid tick, protective clothing, repellents are the one. Again, doxycycline for the high risk exposure, as you see in leptospira. Co-infection with babesiosis and anaplasmosis, I have never seen it, can occur. The treatment, which is again, if you see, compare it with both the spirochetes, leptospira and Lyme's disease, the treatment of choice remains doxycycline. And alternatively, you can give amoxicillin or Syphirex 3rd generation or 2nd generation cephalosporin. When there is a CNS or cardiac involvement, ICU admission with the intravenous antibiotics is essential. Simple arthritis, you can use an oral agent. If it's resistant, then you can use an ceftriaxone. Acrodermatitis, oral therapy for 21 to 28 days or 4 weeks is what recommended. So these are all intermediate diseases which might have an annoying long course, or it may be having a florid short course, both of which I would still recommend using a doxycycline as a primary one. Usually prognosis is good. Resolution occurs within 3 to 4 weeks. Treatment failure is rare. There are no evidence so far of resistance to doxycycline. Immunity is incomplete. Reinfection is possible. If it's a prolonged atypical case or there is a severe CNS and cardiac involvement, better to involve the ICU and the or an advanced center. That's a spirochetal. Any questions on this? Can we go next?
Yes,
The next two are helminthic and protozoal infection that will go with the leishmaniasis and malaria. So leishmaniasis, again, zoonotic disease transmitted by the sand flies called as lutzomia and phlebotomus. I don't think anybody will ask you the detail, but as long as you know it's a sand fly, that's all right. Leishmania has 20 species and complex taxonomy. So, and it's irrelevant to specifically differentiate the species. So, we just need to know that there are multiple species. And there are two major presentations, with the third one as mucocutaneous. So you have visceral and you have a cutaneous. Most of the visceral leishmaniasis are found in the Indian subcontinent, whereas cutaneous and mucocutaneous are in the Western countries. In India, we had this more common visceral leishmaniasis, particularly seen in Bihar, Orissa, Chhattisgarh side, caused by Leishmania donovani. Because of its characteristics and clinical presentation, it makes the person black, so it was called as Kala Azar. Then you have a cutaneous with L. tropica, L. majora, and mucocutaneous with L. brasilensis. The L. brasilensis is a little bit of notorious, and it is a bit of an aggressive one. So visceral leishmaniasis has a long incubation period, 4 to 6 months. From 10 days to 24 months is the range. Symptom starts with a small non-ulcerating nodule at the site of sand fly bite. And after some days or a month, you get fever, chills, sweat, anorexia, cough. It's a very non-specific symptom. The patient will come with a non-specific symptom. So asking the patient whether there were any bite marks or looking for a bite mark would be an important one, as you will see for the visceral leishmaniasis, or whether it was a Lyme's disease. Over the period of time, most of the time when these people come to you, they are little bit in the middle of the disease. The disease has already started and spread. You will see the signs of splenomegaly with the firm and non-tender, hepatomegaly, lymphadenopathy, and hyperpigmentation. The skin lesions, which there can be petechia, there will be gingival bleeding, jaundice, edema, and liver failure and ascites. In advanced stage, when they come late, because there is nothing compelling for them to come to the hospital. So sometimes they keep carrying on with their local treatment and they get missed, and they come with the wasting, malnutrition, and high risk death without any treatment. And this is primarily because of the secondary infection. So these patients get secondary infected and then they rapidly deteriorate. And we try to treat the secondary infection, they don't improve, and then we see the splenomegaly and hepatomegaly, and we still remain confused why this person is dying. The cutaneous and the mucocutaneous, and what we call spoke about just now was a visceral one. This one is a cutaneous and mucocutaneous. So the cutaneous, it comes as shown in the figure as a papules. Then they ulcerate. You get a indurated margin, and all of them are painless. So nobody comes to you or goes to a doctor for that. So however, but once the regional lymph node involves in the groin, like they will come with a pain in the groin with a regional lymphadenopathy. When the nasal or mouth ulceration occurs, then it is called as mucocutaneous, and it is a little bit of risk for the secondary bacterial infection, and they are likely to be lethal. Leishmaniasis occurring in immunosuppressed, particularly AIDS, is very lethal and mainly the visceral form. They come as a late presentation, multi-organ involvement with fever, hepatosplenomegaly, and pancytopenia. For the visceral diagnosis, you need to have a splenic aspirate. It has more than 95% sensitivity, and you will be able to demonstrate Leishmania donovani amastigotes. Other samples you can take is marrow or buffy coat smear from the blood. For the cutaneous, you need to take a biopsy from the edge of the lesion. And with the histology and the culture, you should be able to diagnose it. There is a skin test which is common in mucocutaneous also. It is less sensitive in mucocutaneous, but for the cutaneous, I think they have a protein derived from Leishmania, and you inject it, and then it will similarly like tuberculin test, you get a reaction. The first line of treatment for leishmaniasis is amphotericin B. I think it's a first and second line. Amphotericin is the drug of choice. However, it's been expensive. There has been many dose regimes been recommended. I have not included any one of them because there are quite a plenty. You can have a read. But it all depends upon your financial things, accessibility, and compliance. The other medications are antimonials, particularly used outside India where the resistance to amphotericin B is high. Then we have miltefosine. I have never used it. They are used for oral. Its resistance is emerging for that. Then we have paromomycin, which is a cheaper alternative. There are a lot of IDSA has recommended a lot of combination of therapy. Now, because one single therapy is looking, people are looking at the resistance developing. So multi-drug, like what you do it in tuberculosis, use of combination of amphotericin with antimonials, amphotericin with miltefosine, their regimes are available. None of them would be an exam relevant, but you should be aware that the combination therapy are been increasingly been used. In this, that was for the visceral one. So for the mucocutaneous one, you have a cutaneous may self-heal, treat face or hand lesions. In the new world, especially when there is a mucocutaneous risk, then you should treat it same amphotericin B. There is a poor response to antimonial thing, and alternatives are required in this case. Because this is a tick-borne, you need to have personal repellents, public health measures need to be implemented, and animal control is also important. Any questions for Leishmania, hepatosplenomegaly, Kala Azar? Can we move to malaria? Okay. So I'm sure everybody knows more about malaria than anyone. However, for last 5-6 years, I don't know whether the observation is similar. I haven't seen malaria for last 4 years. As long as I remember, since COVID, I have not seen any malaria. I don't know what's the view you guys have. You guys practice, right? So have you come across malaria lately in India?
No, sir.
Since COVID, I have seen that it has vanished. I don't know why. Dengue is there. Dengue we are seeing, but malaria somehow it is a vanished one. But anyway, it's an important part of our.
The dengue cases are also in decline right now.
Yeah, it is. It's not as bad as it used to be. I remember that.
Yes, sir. Yes, sir.
I don't know whether the other species are also getting bored of the human race. So yeah, just waking up few people who are sleeping. So malaria, it's an important human parasite. We know that it's a genus Plasmodium. We've got a Vivax, Falciparum, Oval, Malarino, Nosley, transmitted by female Anopheles. There are 5 species, and we know that the Falciparum is the most severe form. We are in the endemic, but Africa has more endemic in malaria. In still 2022, they have reported a lot of cases. There has been increasing resistance also. Malaria life cycle, the mosquito bites, the malaria enters into the blood, they form as sporocytes, they enter into the liver and sit there. From the liver, they come out as a merocytes and then reinfect the RBC, and they're responsible for the human diseases. Now, the hypnocytes, which are sitting in the liver, which is classical feature of Vivax and Oval, they are the one which causes relapse. Otherwise, Falciparum doesn't cause relapse. Classical prodrome, high-grade fever, chills, rigors, headache, fatigue, and sweats. 48 hours, every 48-hour fever for Vivax and 72 hours for malaria. You get anemia, jaundice, hepatosplenomegaly. You all know, in severe case, very high paracytemia, you may go in a multi-organ dysfunction. Severe malaria, mainly responsible is Falciparum. Comes with the cerebral malaria, renal failure, like the black water thing. ARDS is known, shock, DIC, high mortality among children, pregnant women, and travelers. Diagnosis, peripheral thick and thin smears, thick for detection, thin for speciation. We have a rapid diagnostic test now available, rapid antigen-based HRP2 deletion. However, Falciparum, they have found out that there is a gene modification and HRP2 deletion, so that may cause a false negative. So still don't entirely depend on the antigen based. If you have strong suspicion, do at least thick and thin smear. We've got a PCR, which is high sensitivity, but it's not diagnostic. And again, anemia, thrombocytopenia, leukopenia, hepatosplenomegaly should prompt you to send the malaria. Now, the treatment is, because there is no broad spectrum helminthic thing, you have to be very specific. So you can't use meropenem and vancomycin for everything. So this is a malaria. It has a very specific treatment. So treat the confirmed cases only. Most drugs acts on the erythrocytic stage, but for the liver, you may require a primaquine. For a non-falciparum, the treatment is still chloroquine. There are few areas where there are resistance coming for the chloroquine, in which case artemisinin-based combination therapy is recommended. Now, because it's a non-falciparum, this should be followed by primaquine for the hypnocytes. However, for those people with the G6PD deficiency, you have to be careful that it may cause acute reaction. For uncomplicated Falciparum, the treatment, again, first line is artemisinin-based ones, as Falciparum is resistant to chloroquine. We are still getting a resistance in Southeast Asia and Africa. Severe malaria is a medical emergency. ICU admission with resuscitation. RV isoniazid is the preferred drug of choice. If that is not available, old school quinine is also still a valid and still can be used. Only thing is you have to have a proper resuscitation and look for the side effects. So the key anti-malarial drug agents are chloroquine, as we spoke about, non-falciparum related. For artemisinin based is a falciparum. Then we have mefloquine and primaquine. This is the concise slide. I'm sure all of you know better than me. I have not treated malaria for at least like 6 to 8 years now. Plasmodium vivax and oval, chloroquine is still there. If G6PD is normal, followed by primaquine. Then Uncomplicated falciparum, you have artemether, lumefantrine, oral, or you can go for the quinine sulfate plus doxycycline and clindamycin. So these were the very controversial thing, because we haven't established a direct relationship between doxycycline and clindamycin. However, a lot of studies and the observational data suggests their utility, but as an addition, not as a replacement. Then you have severe or complicated infection with malaria. Artesunate is the drug of choice. Otherwise, you have the quinine-based therapies. Any questions on this? Right. Prevention, when asked, keep it very simple. Personal nets, repellent clothing, chemoprophylaxis with chloroquine is there. There are vaccines have been rolled out, but they are still not much in the commercially available market. So that's 1 hour, 8 minutes. Special conditions in pregnancy, it's a high risk, poor outcome. Preventive therapies are advised. Severe malaria at risk for the children, and G6 period status required before the primary. Uncomplicated malaria can be treated on the outpatient basis, but a severe malaria needs an admission for sure. So we did cover 6 organisms today. We're still requiring 1 or max 1 more. Okay. Any questions? Should we conclude today's session?
Thank you, sir.
Yeah. I'll conclude.
Yes, sir.
Okay. Thank you, guys. We'll see next time. I think we'll try to cover a few more. We've still got 5, 6 left.
Thank you, sir. Thank you, sir.
Yeah. Thank you.
Thank you, sir.